Hello, I'm Robert McMullen. I'm a psychiatrist that specializes in TMS, transcranial magnetic stimulation, and in psychopharmacology for over 3 decades. And I stopped doing much psychotherapy, although I certainly talk to people and listen to them, a long time ago, so that I could concentrate on the physical interventions we can do. Now, I want to talk about thyroid as a treatment for depression, both relatively low-dose thyroid and very high-dose thyroid. But first I'd like to mention something about TMS that is a little bit related. I gave a talk in Tokyo in November of 2018 on TMS, and I did a lot of reading on this before so that I could understand things and have something to say. There is an interesting phenomenon that happens in TMS in that every once in a while we have a patient who has several different problems, and you do not expect them ever to completely become normal. They're always going to be seeing psychiatrists and taking medicines. But every once in a while we have one of those people who becomes completely normal. They come in and they have panic attacks, they have an eating disorder, they have fluctuating depression, sometimes they have agitated depression, sometimes they're sleeping all the time, they have obsessive compulsive disorder. They have like 4 or 5 different diagnoses. And with medication alone, you don't expect them to lose all of these disorders. But sometimes it happens with TMS. It turns out that the reason may be because of the TMS correcting something called the salient network in the brain. And Jonathan Downer in Toronto, I believe he was the first person that pointed this out. There's 3 main networks and a few more minor networks that are involved with our thinking and our interpreting what's coming into our body and deciding what to do with the sensations and emotions and conjectures that we have. The salient system pays particular attention to things that are salient, things that stand out. Like if you have a picture of 100 different cows and they're red and you have one that stands out that's black, the salient system picks that up. And other things that are important, it pays attention to it. In every psychiatric disorder, there's a dysfunction in that area. So perhaps correcting that system is why sometimes people get rid of so many problems. Now, the one group of people who do not respond to TMS at all are people with major depression who have no distorted thinking. All psychiatric disorders have distorted thinking. If you have an anxiety disorder and you're afraid of panic attacks or afraid of walking across the street, you may know that this is an exaggerated fear, but you still have an exaggerated feeling of danger in the world. And with depression, one feels guilty about things you did in the past or things you should have done. You have a lower self-esteem, you judge people differently, you're more angry at somebody than you should be because of the depression, and so on. Well, if you have someone who has a depression, even a deep depression, but they have no distortions, their self-esteem is good, they have a very objective thinking process about their parents, about their friends. They don't tend to see them more positively or negatively than they should. They don't distort things. They don't have excessive guilt. And these people do not respond. Now, it's possible, it seems to me, that they may not have this dysfunction in the salience system, and it may be that they are one of those people with very low thyroid in the brain, that they have this hypothyroidism of the brain, which I'm going to get to. Now, talking about thyroid, there are two major augmentation strategies that were established with double-blind studies over 4 decades ago. One is lithium, and at the time they used 900 milligrams and it really worked, and now we know that much lower doses, even 150, work. And the other is thyroid, and I'm going to talk about thyroid. It was shown that if you add T3 cytomel, that's the active thyroid hormone, to someone with a major depression who is not responding to antidepressants, then frequently that would help the person come out of depression. Sometimes it works in just a few days or a week, sometimes it takes a month or more, but it frequently works. The studies were done mainly using between 25 micrograms per day and 50 micrograms per day. The thyroid makes 2 different hormones. One is called T4 and is sold as Synthroid, and the other one is cytomel, which is T3. And the T4 is gradually changed into T3, and T3 is the active hormone. They're both in the cell at the same time, so it's possible the T4 is having some activity, and it is really impossible to say that it has no activity. But the cytomel is the primary hormone. The internist and endocrinologist, and some of us psychiatrists too, prefer to have somebody on Synthroid and have it gradually changed into cytomel, because then the lab tests look more normal. You don't get a lab test back with a high T3 level and a low T4, and it lessens the side effects, as some people taking the T3 will feel palpitations or feel a little wired in the morning because the T3 has a more immediate and short-term action. However, it has always seemed that the T3 has more antidepressant effect. In fact, the studies really show that. However, I've been thinking about that lately. The T3 has a half-life of 1 day, so that means once you start taking it, you reach a steady state in 5 days or so, a week or less. Synthroid has a half-life of 1 week, so you would reach a steady state in about 5 weeks. If you're using the Synthroid as an augmentation strategy, and the study is 6 weeks long, that means you would only reach the steady state, the maximum steady level, about 1 week before the study ends. So perhaps it doesn't have enough time to have the benefit. I'm not sure. But in any case, it makes more sense to use the T3 cytomel because it has more evidence. Now, using T3 in a low dose for depression. In the past, we really used T3 aggressively and quickly if the patient's TSH came up as 4 or 5. TSH is thyroid stimulating hormone. So when your thyroid is low, the thyroid stimulating hormone in the pituitary goes higher and is at a higher concentration in the bloodstream in order to stimulate the thyroid to put out more thyroid. Usually, the labs say that the norm is somewhere between 0.5 and 4 to 5. A patient of mine who was on only, I think, 100 or 150 micrograms of Synthroid T4 hadn't taken it in 2 or 3 weeks, and I had a TSH level come back of 400 or something, and an amount I've never seen. If the level is 20 or 80, it's a substantial hypothyroidism. Now, even if the TSH level is lower and normal, you still may get an antidepressant effect from adding cytomel. Something changed a few years ago. The American Thyroid Society, and I think also the American Chemist Society, which may be a society that has to do with laboratory tests, both proclaimed that the maximum TSH should be 2.5. And there's various reasons for this, but the basic thing is the thyroid doesn't follow the usual bell-shaped curve, and most of the thyroid is well below 2.5. So that means that if the TSH is 2.5 or above, we should definitely add the cytomel as quickly as possible. There was a study a few years ago where they observed that the patients who did not respond to an antidepressant were very likely to have a TSH above 2.5. In fact, the biggest predictor of who would become treatment resistant to their treatment were people who had a TSH above 2.5. So both that study and the American Thyroid Society have good evidence that 2.5 should be the cutoff. I use it a lot, and so I've collected many patients where 25 micrograms of cytomel makes a huge difference. I'm realizing recently that I am not pushing people to 50 micrograms often enough. People who do not have a response to 25, you should go higher. And over the last 10 years, I've had a couple of people who really needed 75 micrograms of cytomel, and they were not hypothyroid to begin with. Now, high-dose thyroid. In 1999, there was a paper published by some people at Columbia. Jack Gorman was one of the authors, I remember. And they measured something called transthyretin in the cerebral spinal fluid. The thyroid molecule is a big molecule, so it just cannot easily go through the blood-brain barrier and enter the brain. A protein called transthyretin is necessary to bring it across the blood-brain barrier and into the brain. So what these people did was measure the amount of transthyretin in the cerebral spinal fluid. And people with no depression, they had a range of transthyretin from here to here. And the people that had major depression, their range overlapped, but was far lower. And in fact, the highest transthyretin level in the depressed group didn't even come up to the median in the non-depressed group. This strongly implies that the brain must be hypothyroid in many people with major depression because they don't have enough transthyretin to take enough in. The reason they did this study is because a couple of fellows, Bauer and Wybrow, had speculated that thyroid was low in the brain and had done some studies using very high doses of thyroid, such as 400 micrograms of T4 synthroid, which is about the same as 100 micrograms of T3 cytomel, and had helped people with major depression. I believe that was 20, 25 years ago, and I have treated a couple of people with that, and they did well. One in particular came out of 10 years of depression where she was working on her PhD thesis and got nowhere because she was in bed most of the time and failed on everything I tried. And when I went to high dose synthroid T4, she came out of it and did very well. And last I heard, many years later, she's still doing well. So very few of us used high dose thyroid, and I have not used it very often because it's not really kosher, it's not widely used, it's not really accepted, some concern about what might go wrong. But then a new book just came out by Thomas Kelly. His first name is spelled Tammas, and his last name is Kelly. And he summarizes a lot of recent research in the last 10 years, plus his extensive experience. He uses cytomel rather than synthroid for a reason that I think is very logical. He is going up to very high doses, say 4 pills of 25 micrograms of cytomel. To do this, he starts out with 25 micrograms, and after a week, the person is in a steady state, and if he's feeling okay, no side effects, his pulse is less than 100, then he can go up another 25. So he can go 1, 2, 3, 4. At the end of 4 weeks, he's at 100 micrograms per day, which is a very high dose. If you do the same thing with synthroid, it's going to take you a good 4 months, because if it takes 4 or 5 weeks to reach a steady state, you can't really raise the medicine after 2 weeks, because the medicine they're already taking, or the hormone they're taking, is gradually increasing, and they may have a lot of side effects once they reach 3.5, 4 weeks, and you don't know that yet because they're not there. So if you add in a dose and they get a lot of side effects, you don't know how low you have to go. Also, if you have too many side effects and you stop the medicine or cut the dose, you have to wait weeks for the level to go down. So I think his using the cytomel is the best approach. The main thing you have to watch is the resting pulse, and you want it to not go above 100. If it goes above 100, cut the dose back, or wait a few days and see if it comes down, but wait a much longer time before you try to increase again. Now, the endocrinologist and the internist are going to go crazy about this, and they already do. They are making a little bit of a mistake. They are saying that we are making the person hyperthyroid. And that's not exactly true. We're causing the patient to have a very high level of thyroid hormone, and I guess you could call that hyperthyroidism, but hyperthyroidism is an illness. It's an autoimmune illness, And they are assuming that all the problems with hyperthyroidism is because of the high thyroid in the illness hyperthyroidism. However, a lot of those problems are because it's an autoimmune disorder. For example, hyperthyroidism frequently causes a decrease in bone density, osteopenia, and then a risk of osteoporosis. However, the same endocrinologists use very high doses of thyroid for thyroid cancer. Some thyroid cancers, they just want to suppress it by using very high doses. So they give someone, say, 400 micrograms of Synthroid and follow him for years, and nothing happens to the bone density. The people who take the very high doses of thyroid to suppress a cancer do not get all of the bad side effects that the people with hyperthyroidism have. Another thing that happens with people who need this very high dose of thyroid is that they are fairly amiable with the side effects, or they experience very little side effects. And Bauer did a study, I think, just a couple of years ago, where he took a large number of people who had no depression and a large number of people with major depression and gave them each very high dose of Synthroid up to 400 micrograms. I think 30% of the people with no depression dropped out of the study, and none of the people with depression dropped out. And apparently the people without depression had a horrible time. They had terrible side effects and really felt miserable. And the people with depression maybe didn't have these side effects because they really needed this extra thyroid. I think this is going to be a revolution in psychiatry, the use of this, because I think there's probably a large amount of people that are hypothyroid in the brain, and that's the major cause of their depression. In my lifetime, we've seen quite a few revolutions. One was Prozac coming out, the first of these new antidepressants. We have lamotrigine, Lamictal come out for depression. We have the atypical antipsychotics. We have TMS, which may be a bigger revolution than all of these if we can ever have more people treated and have it more widely known and have it become less expensive. And I'm hoping this high-dose thyroid will be just as important and help as many people as these other revolutions have. This is Robert D. McMullen, MD. I'm a psychiatrist, and I just gave a little explanation of what I think about thyroid.
Thank you.